Hi everyone, good afternoon. This is Dr. Sarkar, second year Child Fellow in Child and Adolescent Psychiatry at Texas Tech University Health Science, Permian Basin. Today we will discuss one of the most common mental health disorder for children and adolescents, disruptive mood regulation disorder called DMDD. DMDD is a mental health disorder in children and adolescents characterized by a persistently irritable or angry mood and frequent temper outbursts that are disproportionate to the situation and significantly more severe than typical reaction of same age peers, significantly impairing functioning at home, school, with peers, and significantly impairing functioning also in school also. So the symptoms appear before the age of 10, often differentiated from bipolar disorder by the absence of distinct episodes of manic or hypomanic episodes. DMDD was added to the Diagnostic and Statistical Manual of Mental Health Disorder, we call DSM-5, in 2013 and is classified as a mood disorder. Symptoms of DMDD resemble many other disorders. That's a differential includes ADHD, Attention Deficit Hyperactivity Disorder, Oppositional Defiant Disorder, Anxiety Disorder, Childhood Bipolar Disorder, Intermittent Explosive Disorder, Major Depressive Disorder, and Contact Disorder. Sign and symptoms of DMDD. Children with DMDD show frequent, severe, recurrent temper outbursts, 3 or more per week over a year, and is observed in multiple settings like at home, school, with peers, and these children mood are never touch the baseline. They are always kind of hyper. And this outburst can be verbal or behavioral. So verbal outbursts are often described by the observers as rages, fits, tantrums. Temper outburst will vary between children with type, nature, and settings, and it is very important to talk with parents about the nature of the outburst and their triggers. Unlike the irritability that can be a symptom of other childhood disorder, such as oppositional defiant disorder, anxiety disorder, major depressive disorder, and the irritability displayed by children with DMDD is not an episode or a situational or a situation dependent. Furthermore, most children with DMDD display symptoms that meet the criteria of attention deficit hyperactivity disorder, we call ADHD, and a similar portion of children with DMDD display symptoms of similar to DMDD. Originally, a distinctive disorder with DSM-5 was derived from severe mood dysregulation disorder, we call SMD, and had requirements for the list 3, like hyperarousal symptoms such as pressured speech, racing thoughts, intrusive behavior, distractibility, insomnia, agitation, and these are not included in most of the recent DMDD criteria. We can talk a little bit more about the ADHD. ADHD, we call the Attention Deficit Hyperactivity, is a neurodevelopmental disorder characterized by inattention, hyperactivity, impulsivity. Some kids have all 3 symptoms present there, and a lot of children with DMDD, they are having with the ADHD. So in that situation, what is happening to them? They impaired executive functioning, structural and functional abnormalities in the brain parts like the striatum and the frontal lobe, so with some gene mutation. So patients with DMDD often exhibit symptoms of ADHD due to their inattention and distractibility. Here I can say something that sometimes some symptoms are overlapping with DMDD and ADHD. It's like crisscross symptoms. Another common also the mental health disorder is major depressive disorder, is a mood disorder characterized by daily or near daily symptoms of down or depressed mood for all and almost all the day. And DSM-5 requires for the diagnosis of individuals with MDD need 5 to 9 criteria for at least past 2 weeks period, and with significant impairment of their daily life and the function. That's very important, and are not caused by other medical condition or substance use. MDD often presents with differently from comparing somatic complaints, especially for children and adults. There is a big difference for MDD. Children are usually complaining of somatic complaints like stomach aches, hyperactivity. They don't usually present with typical sadness like the adult do. So that's the difference for major depressive disorder in adult and the adolescent. Anxiety disorders are broad-based of disorders that are in generally characterized by excessive fear, emotional response, or to a real or perceived imminent threats. And anxiety, the anticipation of future threat. The objects or the situation that are source of fear, and anxiety a person experiences which can often lead to avoidant behavior and used to characterize the different anxiety disorder. So conduct disorder, this is like another type of disorder. We can talk a little bit about with conduct disorder. Is a behavioral disorder characterized by repeated persistent patterns of behavior that violate the rights of others and disregard the major societal norms and rules. So while both with DMDD and conduct disorders are associated with argumentative and defined behavior, so DMDD is distinctly differentiated from the conduct disorder by DSM-5. Individuals with DMDD experiences conduct disorder is described by lack of remorse and repeated physical harm and threats to harm to people or animals. Another disorder is substance use disorder. Substance use disorders encompasses a broad range of specific diagnoses, but they all generally have the characteristics of cognitive, behavioral, physiological symptoms that cause some of to continue to use a substance despite significant impairment. Here I can tell something like the substance use disorder people, they knows they are going to harm themselves after using the drug, but they cannot control their urge, so they are continue to use that substance use. So pathophysiology, let's talk a little bit more about the pathophysiology of this DMDD. So compared to children with bipolar disorder and ADHD, the functional MRI studies suggest that underactivity of the amygdala, a parts of the brain area, plays an important role in interpretation and expression of emotion. Novel stimuli is associated with dysregulation seen in DMDD. Another fMRI result shows hypoactivity of amygdala, and the early attention process deficits mirror those found in depression and ADHD. So in youths with DMDD showed markedly greater activity of the medial frontal gyrus, a parts of the brain and anterior cingulate cortex compared to the youths. Diagnostic criteria describe duration, setting, and onset of disorder that make a diagnosis. Of note, patients' outburst must be present at least 12 months and occur in at least 2 or more settings, like at home, at school, with peers, and must be severe at least one setting. Symptoms apply before the age of 10, and diagnosis must be made between 6 to 18 years. DMDD cannot be diagnosed after 18 years, and DMDD cannot be diagnosed before the age of 6 years. Evaluation of DMDD requires the professionals, usually child psychiatrist or a psychologist, conduct comprehensive psychosocial assessment to differentiate DMDD diagnosis from other depressive anxiety disorder, with particular focus to the nature of the irritability that is present. So treatment. A recent studies indicate that children diagnosed with DMDD are almost 12.5% or more likely to be prescribed psychoactive medication, and 7.9% of children likely to be prescribed antipsychotic medication than children diagnosed with bipolar disorder. So again, the treatment goal is, number one is behavioral therapy, number two is medication. So what are the medication we prescribe? Like antidepressant, we call the SSRIs, selective serotonin reuptake inhibitors. We call fluoxetine, paraxetine, sertraline, citalopram, Lexapro, all of them are there. And also, if patient has DMDD with ADHD symptoms, we need to start treatment with stimulant medication called the methylphenidate. Why it is important for parents to have their children for early evaluation by a psychiatrist? Because early diagnosis and intervention, it prevents long-term complication of the children in future complication. Children with DMDD are at risk for developing depression and anxiety later in their life. So that's why it is very important, and I try to focus this DMDD for all of us. Thank you for all for listening. Again, if you think your child needs an evaluation, don't wait. Don't hesitate to contact with us. Don't damage their future. We are from Texas Tech Psychiatry, Permian Basin. Our phone number is 432-610-1156, or you can email us with the all documents for appointment, pbpsychadmin@ttussc.edu. You can Google it in our phone number or the email address. We are very prompt to respond with that. Thank you all, and thank you for listening.